Diagnosis of cardiac rhythms. Lecture number 2. Common terminology: supraventricular versus ventricular rhythms. The differential is made on the basis of QRS duration. If the QRS complex is narrow, less than 0.12 seconds, the ventricular myocardium is depolarized rapidly. The rhythm is supraventricular in origin. If the QRS complex is wide, greater than 0.12 seconds, there is a delay in the spread of the electrical activation throughout the ventricles. The origin of the rhythm may be in the ventricle itself. Premature atrial contraction, PAC. P waves differ from normal. P waves appear early. P waves are followed by a normal appearing QRS complex. Mechanism: PVC PAC. Premature ventricular contraction, PVC. No P waves present. QRS complex is wide. Ventricular tachycardia, VT. 3 consecutive PVCs, at a rate 100 bpm. Non-sustained VT, less than 30 seconds. Common terminology: CONTED. Arrhythmia. Generally referred to as any rhythm other than normal sinus rhythm. 3 general mechanisms that can cause arrhythmias. Disorders of impulse formation. Altered automaticity. Triggered activity. Disorders of impulse conduction. 3. Reentry. Mechanism of arrhythmias. Reentrant tachycardia. Rhythm is secondary to a loop in the electrical circuitry, the reentry pathway, resulting in tachycardia. Requires unidirectional block, with recovery. Slowed conduction through loop. It may occur within the synode, the avenue node, or actually any ectopic foci in the atria or ventricles. Mechanism: reentry tachycardia. 2. Diagnosing cardiac rhythms. Irregular supraventricular rhythms. 1. Sinus rhythm: normal sinus rhythm, rate equals 60 to 99 bpm. Sinus bradycardia. Rate 59 bpm. Sinus tachycardia. Rate 100 bpm. Sinus rhythm criteria. 1. Every QRS complex is preceded by a P wave. 2. P waves appear normal, that is, they are of sinus node origin. A normal morphology. 1. P wave duration less than 0.12 seconds, less than 3 boxes. 2. P wave height less than 2.5 mm, less than 2.5 boxes. The normal axis. 1. P waves is upright in leads 2, 3 and AVF. 2. P waves is negative in lead AVR. 2. Paroxysmal atrial tachycardia, PAT. Reentrant tachycardia of supraventricular origin. With a rate of 120 to 180 bpm, narrow complex. P waves may or may not be visible, depending on the rate. If present, P waves are usually regular and inverted in lead 2, they may be seen before, during, or after the QRS complexes. Usually idiopathic, but can also be seen in RHD, COPD, MVP and digitalis toxicity. Paroxysmal atrial tachycardia. Paroxysmal atrial tachycardia. 3. Atrial flutter: atrial rate 250 to 350 bpm. Be characterized by rapid, undulating flutter waves. 1. Are best seen in leads AVF and V1. 2. Have a longer duration and a greater amplitude than a normal P wave. 3. Have a sawtoothed appearance. See, there is always some degree of avenue block present, 2 to 1, 3 to 1 or variable, which is why the atrial rate is always much greater than the ventricular rate. Atrial flutter. Atrial flutter, CONTED. D. Carotid sinus massage, may exaggerate the degree of avenue block and consequently slow down the QRS rate, to assist with a diagnosis. This makes the flutter waves more obvious. 4. Junctional rhythm. A impulses originate in the avenue node with retrograde and antigrade conduction. B. QRS complexes are narrow and regular, this is still considered supraventricular. C. P waves may be inverted in leads 2, 3 and AVF and may occur before, during or after the QRS complexes. D. Junctional rate equals 40 to 55 BPM. I. This is usually an escape rhythm due to synode dysfunction or digitalis toxicity. Junctional rhythm. Junctional rhythm. Avenue nodal reentrant tachycardia, AVNRT. One of the most common causes of PSVT. P waves may not be visible or may occur before, during or after the QRS complexes. Two pathways usually exist: slow, anti-regrade conduction, and fast, retrograde conduction. D. More common in younger patients. E. Abrupt onset and offset. 6. Avenue reentrant tachycardia, AVRT. Another common cause of PSVT involves an accessory pathway, 1 to 1500. Usually utilizes the avenue node as the antiregrade and the accessory pathway as the retrograde limbs. Orthodromic AVRT accessory pathway may be concealed. In 10%, impulse travels retrograde across AVN, and antiregrade over accessory pathway. Antidromic AVRT pre-excitation present. Pre-excitation. Pre-excitation, impulse travels anterogradely th avenue node plus accessory pathway to ventricles. Examples include pre-excitation syndromes. Wolff-Parkinson-White syndrome. Pre-excitation plus tachycardia. Lown-Ganon-Levine, LGL, syndrome. Mahaim fiber tachycardias, Wolff-Parkinson-White, WPW. A supraventricular rhythm originating in the synode with normal and regular P waves. B. PR interval is abnormally short, less than 0.12 seconds. C. QRS is wide with a slurred upstroke, aka the delta wave. Delta waves are due to the accessory conduction pathway, bundle of Kent, from the atria to the ventricles, that bypasses the avenue node. Must manifest a tachycardia at some point in time. E. Rx, procainamide, Wolff-Parkinson-White. B. Irregular supraventricular rhythms. 1. Sinus arrhythmia. 2. Wandering atrial pacemaker, WAP. A. Pacing is from various foci within the atria. B. Heart rate less than 100 BPM. C. Contour or shape of P waves vary from beat to beat. In a single lead, always try to look at lead 2. Associated with variations of PR and PP intervals, resulting in an irregular rhythm. E. A common cause is rheumatic heart disease. So, DX criterion, 3 consecutive P waves with different morphologies, on a single EKG lead. With a heart rate less than 100 BPM. Wandering atrial pacemaker. Wandering atrial pacemaker. 3. Multifocal atrial tachycardia, MAT. A multifocal atrial tachycardia, MAT, is similar to wandering atrial pacemaker, except that the heart rate 100 BPM. Again, you must have 3 different consecutive P wave morphologies on a given lead. Again, examine lead 2. C. Irregular rhythm. D. Usually associated with end-stage COPD. E. Rx. Control the rate and treat the underlying problem. Multifocal atrial tachycardia. 4. Atrial fibrillation. A random chaotic depolarizations of the atria at rates greater than 300 BPM. B. no effective pumping of the atria takes place. You lose till to 25% of CO, aka the atrial kick. C. Irregular rhythm may occur in any clinical situation which causes hyperthyroidism, or also with EDOUs, holiday heart. E. Rx, rate control and anticoagulation. Atrial fibrillation. Atrial fibrillation. The ventricular rate can be either rapid or well controlled, depending on the conduction through the avenue node. See ventricular rhythms, these are generally regular. 1. Idioventricular rhythms. Rhythm originates in the ventricles, giving rise to widening bizarre QRS complexes. B. The avenue node and sometimes the synode are not functioning normally. D. The axis of T waves is in the opposite direction of the QRS complexes. E rate equals 20 to 40 bpm. Idioventricular rhythms. Idioventricular rhythm. 2. Accelerated idioventricular rhythm, AIVR. A often develops following an acute knee. B occurs in short bursts and lasts less than 20 seconds. C rate equals 40 to 120 bpm. Accelerated idioventricular rhythm. 3. Ventricular tachycardia, VT. Once again, you see broad and bizarre QRS complexes, greater than 0.12 seconds. B often with an abrupt onset. C rate 120 to 140 bpm. D can be monomorphic or polymorphic, torsades. Look for ventricular capture and fusion beats. Capture beat, a normal atrial beat breaks through before the ventricular beat has occurred. Fusion beat, the atrial beat breaks through during the ventricular beat. Monomorphic ventricular tachycardia. Polymorphic ventricular tachycardia, torsades to points. Wide complex tachycardia, SVT/VSVT. QRS duration. Less than 0.14. Greater than 0.14. SO avenue dissociation, fusion, capture BTS. Absent. May be seen. Responsive vagal maneuvers. Plus. Dash. Concordance of QRS complexes in V1 V6. Axis, extreme axis deviation. Rare. HOCAD. Uncommon. Usually present. 4. Ventricular fibrillation, VF. Chaotic depolarization of the ventricles. Loss of organized QRS complexes. Complete loss of the cardiac contractile function. Circulatory arrest comes about within seconds. The most common cause of sudden cardiac death. Ventricular fibrillation. Ventricular fibrillation. General rule for arrhythmia rates. Rhythm rate, BPM. Normal sinus rhythm 60 to 100. Idioventricular escape rhythm 20 to 40. Junctional escape rhythm 40 to 60. Accelerated idioventricular, AIVR, 40 to 120. Sinus tachycardia, ST, 100 to 150. SVT and ventricular tach, VT, 150 to 250. Atrial flutter and torsades to points 250 to 350. Atrial fib and ventricular fib, 350 to 450. Excludes street, atrial fibrillation and atrial flutter. D. Arrhythmias, review. Regular narrow complex tachycardias. Sinus tachycardia, normal P waves, HR usually less than 150 bpm. Paroxysmal atrial tachycardia, PAT, P waves are different from sinus, may be inverted, or absent. Atrial flutter, large sawtooth flutter waves, +/variable avenue block. Avenue nodal reentrant tachycardia, AVNRT, most common form of PSVT, +/P waves. Avenue reentrant tachycardia, AVRT, a common form of PSVT, +/P waves, plus accessory pathway. Irregular narrow complex tachycardias. Atrial fibrillation, no recognizable P waves. Multifocal atrial tachycardia, MAT, 3 consecutive P waves with different morphologies, usually associated with COPD. 3. Any regular SVT with variable avenue block, examples, PAT array. Flutter with variable avenue block. Approach to EKG interpretation. Always. 1. Rate. 2. Rhythm, includes analysis of intervals. 3. Axis. 4. Hypertrophy. 5. Ischemia, injury, or infarct. Atrial, non-sinus, rhythm. Multifocal atrial tachycardia. Atrial flutter with 2-to-1 conduction. Sinus rhythm with unifocal PVCs. Atrial fibrillation with a slow ventricular response. Sinus rhythm with bigeminal PVCs. Atrial fibrillation with RVR.